Hello, and welcome to the Ask Nurse Linda webinar for the month of June. It's always pleasant being with you, and I open with that each time because I sincerely mean it, and I just want you to know that I really look forward to this day of the month. So I am a woman with brown hair, lightly pigmented skin. Today I'm sitting behind a map of the world, which is blurred, so it won't be distracting. So I'm out of pocket today. So just so you know, I have on a cream blouse. It has blue and yellow flowers on it. I got it on sale. So, everybody loves a bargain. And so I wanted to bring up, first of all, on July 9th, which is just around the corner, it's our professional webinar, and we're going to be talking to some very clever individuals that have started a project about promoting awareness of pressure injuries and how to avoid them. And so, it's better if you don't get one. If you get one, you can heal it, but it takes time, and that area is always fragile afterwards. So it's always best if we can leave pressure injury out of our picture of life. So that would be a good thing. So we'll hear more about that on July 9th. Now I'm going to cut right to the questions. And the very first question that I want to talk about is a question about will the changes in the government affect individuals with spinal cord injury and others with paralysis. And so we have to wait and see how that is going to be. And one thing I do know is that it may affect the Christopher and Dana Reeve Paralysis Foundation, in particular, the National Paralysis Resource Center. So if you turn into the Christopher Reeve webpage, and right at the top, you'll see a link in the chat box there on how to get there. But right at the top, there will be a link that you can click right onto advocacy. And so there's a way that you can contact your representatives to give your opinion about that. Now, it's up to you if you choose to do that or not. It would be helpful if you did. But it's completely up to you. There is a pre-formed letter that you can sign and send, which is important because if they get a lot of these letters if the senator or the representative gets a lot of letters, they would think, gee, people are really concerned about this. So we really need to pay attention to this matter. Or you can write your own letter, or you can change the letter that's on you can use the letter that's there as a format if you're not quite sure what to say or how do I get started. So there's a lot of things that you can do, and then you can put it into the link there, and it will automatically be sent. You put in your zip code and it automatically gets sent to your senators and your representatives. So it's really easy. And I know I myself personally, but I think many people would appreciate you doing that. So we had some questions from the professional webinar that we just had at the beginning of this month. So I'm just going to run down those first so that we can be sure everybody's gets their questions answered. Now, this one was really interesting right up at the top. Are there any issues for SCI patients getting dental surgery? And since the Reeve Foundation caters to anyone with paralysis, we're just going to say for people with paralysis, because the things that you might want to think about are going to be the same. So for individuals with paralysis, you want to think about getting into a dental office if you're having dental surgery in the dental office. Or if you're going to the hospital, you want to think about, how you're going to be cared for. Are you going to have your pressure reducing seating cushion? If you go into a dental chair, you want to make sure that you move your cushion from the wheelchair into the dental chair if you have to be in a dental chair. Now, every once in a while, dentists will treat your mouth directly from from your own personal chair, which is lovely. But for people, especially that can't tip their heads back too far, it's very helpful. But usually when you're having dental surgery, your head is tipped back and your mouth is held open by one of those things that they put in your mouth to keep it open. It stretches it real wide so they can get in there. And so, of course, you want to be careful about any saliva going down, especially if you have problems swallowing. You want to be careful that no saliva gets down in your throat or in your windpipe. Now, they use that little device that pulls the saliva out of your mouth, but you just want to be double sure that they're aware of that you do have swallowing difficulties if that is an issue for you. If you have hardware, if you've had a spinal fusion, or if you've had some kind of repair into the back of, especially in the back of your neck area, you want to be sure that they know that you might not be able to tip your head back as far as may be needed. Now, usually you're in alignment, so it's okay in the dental chair, but those are some things that you want to look forward to and discuss, just so that you're sure, that they're watching these things, but you want to talk, you want to ask questions about it, so it brings it to the forward of their mind. Because as with any kind of healthcare procedure that you might be having, they're thinking about the procedure and they're thinking about what they need to do. They know your medical history and they know what to watch for. But if you talk about it a little bit, maybe at a pre-op visit, or maybe when you're first getting there, and kind of remind them, kind of puts it in the front of their brain. So that's, it's just a little tip to help you. I'm sure nothing's going to happen, but, we always want to be as safe as we possibly can be. Now, some people have autonomic dysreflexia, especially with the higher level injuries in spinal cord injury, or sometimes with neurological disease, sometimes with head injury. People get autonomic dysreflexia. So you might want to alert them. Now, the thing that's going to be going on is up in your mouth. So that's probably going to be above your injury. But if you have a head injury, or if you have neurological disease, it might trigger your AD especially. It can with spinal cord injury as well. Usually it won't when it's up above the area, but sometimes, your body just gets shaken with maybe drilling or different things that are going on in your mouth. So always mention, take the Christopher and Dana Reeve wallet card. That's an emergency card for AD. Be sure they have that ahead of time. Be sure you bring it with them, with you at the time of your appointment, so that everyone can be alerted. If you're going to the hospital and there'll be multiple staff taking care of you, bring several of them, so that everybody will be alerted and will be knowing to watch for these things. So this can be an important little piece of the puzzle if you suffer from something like that. Okay, Peter writes in, transfers to and from personal chair to the dental chair. That is a really, really tricky thing. You might have to have somebody lift you, or you might need a little help in doing that. Sometimes the dental chairs go down low enough that you can do a wheelchair transfer if you do those on your own. Sometimes you have to go up a little bit. The equipment is always a little different. The arms, sometimes they flip to the side and they go way out of the way, and sometimes they just kind of drop down and they're kind of in the way. So anyway, Peter's not sure about using his Roho in the dental chair. If there's, but it helps to have that. The dental chair is going to be cushioned, but it's not going to have pressure dispersing cushioning on it. So sometimes if you put that big cushion on the dental chair, then when you lean back, your back is a little bit out of alignment with your hips. So you kind of have to manipulate that around. But if you're going to be in there for any length of time, you're not going to have any protection unless you have your pressure dispersing equipment. And then also, is there space to move the power chair or manual chair to get close enough for transfer? So yes, all of these things are really critical. Now, I know where I go to my own personal dentist, I'm always on the lookout for these things. And yes, I could put a manual wheelchair. He's got a private office. It's got big rooms. It's nice in that regard. You could get in and out. I know where I would have to take my mom, and she used a wheelchair because she had problems with her knees and couldn't walk because of her knees. And so it would be a challenge to get her in. It was a manual push wheelchair, and it would be a challenge to get her in, but it could be accommodated into the dental chair. Now she could stand and transfer, but she couldn't walk, and so that would be a challenge for her. The room where she would go for her dental X-rays was, I would say, not at all wheelchair accessible. However, the staff were very kind and very courteous, and they would join together, and four of them would lift the wheelchair and kind of slide her in sideways. It wasn't ideal, but she had to go to this particular dentist because it was in a hospital, and she had to have access to emergency care while she was in the dental office. So anyway, as things get so complicated sometime. But anyway, they were they're very thoughtful about doing it. If you go to your dentist and it's just the dentist and the hygienist, they might not be able to get you into that X-ray, in which case the dentist can still look in your mouth and see what's going on there. So there's all different kinds. Now, if you're not sure and you have your dentist, you love your dentist, you want to stay, they'll usually try to help you work something out. If you're just like, well, it's the dentist, I can go see any dentist, and you don't have really a lot of feelings about your dentist, you can call around. You can take a tour of the office before you go, usually, explain your situation. I'd like to come see, or, you can ask them, are you wheelchair accessible? And everybody's going to say yes. Oh, yes, we're ADA compliant. And yet, on the other hand, when you go, it's never quite as it appears to be. So it's always good to check out. If you belong to the Christopher and Dana Reeve Peer Mentoring Program, you can ask your mentor, who's usually familiar with the area, or ask other people. If you have friends, if you go to therapy and you see other people, can you recommend a dentist where I can get in and out of the office? Because, people who are going are knowing these kind of things. So that was a very interesting question. Kind of gets into a lot of different information. There's a question about pressure injuries, and there's been a couple of questions about pressure injuries, and we are having that special program about avoiding them. It's not so much about treatment of them, but there's a question about wound creams. Can they be used once a wound is healed, and are these creams still helpful? And the creams that are being mentioned, there's a lot. You can go on the internet and there's a lot of wound creams, but a lot of them are formulated for other things than pressure injuries, like if you get a cut or if you have surgery and your wound's not healing, and there's a lot of these things. There's a lot of creams you can put on top of the skin after the wound has healed to help ease up that scar and make it a little more flexible. So, you need to check with your healthcare professional, because you don't want to put anything, if the wound is open, you don't want to put anything in there that you've stumbled across or your friend's using, or you always want to check with your healthcare professional, because they're going to give your treatment plan to you for what's needed for you. So people have pressure injuries, they talk to their friends, they get different information, but what you need to do is what your physician has ordered, and make sure that you're following that plan, because they're looking at your wound, and each pressure injury wound, like each individual, is unique unto itself. So you need to check out those kinds of issues. Now, somebody was asking how to heal a stage 4 pressure wound, and that's a wound that goes all the way down into the bone. And so, by the time they get to stage 4, that's like the maximum of pressure wounds. That's the highest that you can get. And so you want the wound to heal from the inside out. Now, the skin is going to want to close over that wound, because that's what skin does. It's protecting your body, and it's going to want to grow and close over that wound. But if the wound's not healed deep inside, it will form a little pocket there, and usually infection will start getting in there, and it will burst open. It can, if the drainage from the wound cannot get out because the skin has closed over, that drainage is going to go somewhere, and it's just going to cause a whole lot of problems. So we have to get leave the skin open until the wound heals from the bone up into the surface of the skin. It's a very important part of wound care. Now, at the stage 4, you want to be sure that you have a wound care specialist who's taking care of that wound because it's pretty serious. The way that you heal a wound is to stay off of it. And people will say, well, I'm sitting on my cushion, or I'm doing this, or I'm doing that. But the unpleasant reality is you have to stay off the wound for it to heal, because that bone, when you're sitting on it, or if you're laying on your side, or wherever that pressure sore is on the back, pressure injury on the back of your head, your elbow, wherever it is, you have to remove the pressure, because the bone is what's pushing on the inside of your skin. So if this is a layer of skin, that bone is taking the fat and the tissue, and it's creating pressure that's mounting all the way up. So it's pressure. So wounds come from the inside out with pressure injury. And so getting that wound closed up is going to be important. Those really deep ones are kind of hard to heal. They take a long time. And people will say, well, I can't stay off of it for that long. And sometimes life does get in the way where you need to do different things. It is either not going to heal if you keep putting pressure on it, or it's going to take so long that it just becomes a natural part of your life that it's there. So you really need to get that healed up. You need to pay attention to it and really give it the attention that that wound deserves. There are some more advanced treatments that people are using, some with some electrical stimulation to the wound. These are kind of, off unusual kinds of things. But if you have a wound care specialist, they might recommend something like that, stimulating the circulation and the blood flow, and getting that wound to heal up. Another thing is the wound vac, which is kind of a neat thing. It's been around for quite a while. And it's a vac because it's a vacuum. And it's so you put the treatment in the wound that needs to be done. And then you put like a seal over this, completely sealing off the wound. And this hose is attached to the wound, which is attached to a vacuum. So there's this constant pressure drawing out all that exudate, all the fluid and the gunk that's in that wound. And it's very gently. The vacuum is not strong enough to damage the tissue, but it's strong enough to get the gunk out of it. And so that's very helpful. At a stage 4 wound, you might see the edges of the wound, or any open wound. If you start to see the edges of the wound rolling in, so there gets to be a little roll of skin around the edge of the wound, that is the way the skin is sealing off the edge of the wound, but it's not closing it. That rolled in skin won't ever grow together. So that's why you need a specialist to see, to make sure that that doesn't happen, and to treat it if it does. Some people will have to have surgery to close these wounds. Now, people will say, oh yeah, that's good, I'll have surgery and it'll be all done. Typically, after you have surgery, which will include cleaning out the wound, maybe moving muscle tissue over that area where the bone has been poking at the skin, to give it some muscles to relieve the pressure on the inside, on the underside of the skin. And so they will do a muscle graft and rotate a muscle around to give you some protection. And then they'll make an incision that, you can't like sew up a hole like this. You have to have an incision that you can close up. So they'll bring the skin over and rotate some of the skin around. So it makes a great big scar. Now that scar tissue does not have the stretchability that skin has. Scar tissue will crack open real easily. So once you have a pressure injury, once you've had the surgery, it's going to be very difficult to maintain that. It can be done, but you have to be ever so cautious about it. And so you want to not have the pressure injury in the beginning, but sometimes things happen. It's probably not your fault. Don't think like, don't take that on. It's probably the autonomic nervous system is not able to do what it needs to do. So after you have surgery, usually it's 9 months to 1 year that you are laying flat in bed. And oftentimes the doctor will have you sign a contract that is what will be happening. So you cannot sit on that area, you cannot roll on that area. And it takes about 9 months to 1 year for that to heal up. Otherwise, it just breaks open again. So, it's a big commitment when you get these big wounds, but, you just have to, ride it out. People do. And when they're finished with it, it's over. And then you move on and you do your pressure releases and you keep going because these things can be healed. But sometimes it takes a little more strategy than we first think. Another surgery question, since we're in here, for my cataract surgery, a breast biopsy, dental surgery, they had hypnosis instead of anesthesia and was furnished by a medical doctor who's very skilled. I had 3 sessions prior and then a session following him. I was hypnotized to modify any discomfort before, during, and after, and they were shocked at how well it went for them, and that does happen. If some people um, do different kinds of alternative medicines, and that works great for them. You have to remember, though, if you're having surgery in an area of your body where you don't have sensation, the nerves are still going to react to that. It might not work for you. So talk with your doctor diligently before you do that. That's going to be very important to making sure. If you have autonomic dysreflexia, that nerve is going to react in some way. So you really need to have some sort of anesthesia. So I'm happy that worked for that lady. I would wish it would work for everybody, but it might not work for the majority of people. So be cautious with that. Oh, Leon, I met you in Chicago and I remember you. Thank you. It was the highlight for both of us. Well, it was a highlight for me too. What's the best way to get scar tissue to toughen up? So there are some creams and tapes. It's called scar tape. There are scar creams and scar tape. You can buy them over the counter. You can get them by prescription, but you can buy them over the counter. The tape works better than the cream, and you can put that on. It will help reduce the scar. So if you have less scar, you have less option of that scar breaking open. Now that's after things are healed, and that's after the scar is well healed, and you can use the scar tape. If you're doing it right after surgery, talk to your healthcare professional, talk to the surgeon who did that procedure, because he may or may not want you to use that. But after it's all healed up, it will still work if you put that scar tape on there, and it will reduce the scar so you have less scar. So that really helps a lot. So Leon, thank you. I'm so happy to hear from you. Oh my gosh, I love it. Somebody I know. That's so exciting for me. So it's great to hear from you, Leon. Let's see what else is going on. They're looking for emotional support, someone who's injured at 15, now 23, moving to the next phase of young life. And that is really a challenge, because it's a challenge if you have paralysis or if you don't have paralysis, making that phase from adolescence to adult living, it's a huge shift. It's a wonderful time of life. And so you want to get the most out of it. And so I think one of the best things that you can do is either have a counselor or a therapist that you're talking to that can help you kind of go through the issues that may come up and learn how to deal with them before they come up. So that's very helpful. Another thing that has been wonderful for so many people is to join that peer mentoring program. And they will connect you with somebody who's either going through it or has been through it. And these are people who are educated in how to help you, not just, well, let me tell you what to do. So they're very good at what they do, and it really works out quite well. So there's a couple of things. Of course, there's always your parents that you can rely on for support. They might not know the ins and outs of living with paralysis, and so they might not, be able to see what's coming. So if you get a peer mentor, that's really very helpful. Um, how are we doing with the caregiver situation? Are spouses being paid to care for their loved ones? I see that on TV. Different states have different things. There are companies that start up and they'll say, we will pay your caregiver, and they'll have a commercial, and my granddaughter's taking care of me, and they always say, and she gets paid at the end of the shift. She doesn't have to wait for a check, and all this is going on, and then in a month or two they're gone. So, it's kind of a hit or miss kind of thing. Some states allow it, some states do not. You have to check with your own state, but it seems to me like it's an important thing. I know it's an important thing, but it seems to me like how that all works out is kind of a bit of a mystery, because it's here and then it's not here, and so we just have to see. If you see an ad for one, if you find out of a company that's doing that, find out, how much do you have to pay them to pay your caregiver? Maybe you're paying so much and yeah, they're getting paid. Maybe you would just pay your caregiver directly instead of paying another company. You have to look at the ins and outs of each individual company, because no two are exactly alike. A family's looking for respite care, and how is there respite care available? Well, there sure is. A lot of long-term care facilities will have respite care. You have to call around and find. It's usually out of the pocket fee. It's not usually covered by insurance, but talk to your case manager and see if it can be arranged, because sometimes those insurance case managers can do things with insurance that are really quite miraculous. If you call the number on the back of your insurance card or the number on the back of your Medicaid card, and you call that number and ask for your case manager, you might not have one assigned to you. Be sure you get one assigned. They're supposed to be assigned with any catastrophic condition like paralysis. There's supposed to be one automatically assigned, but if you're not squawking about it, there might not be. So ask for your case manager. They might say, oh, we need to assign one to you, and then wait until that case manager calls and then ask if there's any assistance and find out how you can arrange that kind of thing. They might be able to move some funds around within your insurance policy. Works the same in Medicaid, or it might just be, no, we're not paying for it. But there is respite care available. Oftentimes, most often, is paid out of pocket. A company, a group, I shouldn't say a company, a group is working on wheelchair maintenance program in Pennsylvania. Are there other programs? Yes, there are programs where people maintain wheelchairs for people who need that help. You need to call around and ask. Sometimes different organizations do that as their gift to the community. If you go back to your rehabilitation hospital, or if you need repair, you call the vendor who cared for that. There's opportunity there. If you have the chance to go to one of the abilities expos, Permobile will sets up a chart, and if you go to the expo, which is free, they will repair your wheelchair while you're there, which is a lovely, lovely thing. You have to sign up early, because those spots go by pretty darn fast if you're going to get your wheelchair repaired, and that is something that needs to happen pretty quickly. So look around. It's hard to find them, but once you find them, it's good. Sometimes you can call different organizations. They might have, like, I know the MDA Society has an equipment closet. The VA, if you go to your local VA chapter, they sometimes have an equipment closet, and they will give you supplies. Now, some people will give you, like, I need a new tire, or my brake is broken, and they'll give you a new brake. And so they'll help you out in that way. Some people will not do the work of the repair because of litigation, if something would go wrong. But if you go back to your old rehabilitation stopping grounds, talking to your doctor, asking around in the community, there's generally some place that will help you out with that. You might need to go to a medical supply store where the vendor would come in and repair the chair if you got it from a medical supply store. So going back to the source is a good thing to do. Let's see. As parents with the evolving needs of adult children, this person's had written in and is hoping that there's some kind of, I think, some kind of help, or their just needs are evolving. Be sure and take advantage, if you're a parent of an adult child, if you're a parent of a child, if you're a spouse, Look at your health policy and find out. Most policies, most Medicare and Medicaid allow 2 weeks per year for mobility training. So it might be mobility, and that can be worked into different kinds of things. If they need to learn how to turn in bed, if they need to try to learn to feed themselves, it doesn't mean training to get up and walk. It can be morphed into a lot of things, and it doesn't mean, and it most likely will be outpatient. It doesn't mean 2 weeks solid. You could do it every Monday for 14 weeks. You could do it 2 times a week. However it's recommended, so that you have some time in between. And look and see if there are different things that might improve the mobility for your person in any way, shape, or form. The doctor will probably have to write a letter of medical necessity to activate it with the goals of what the therapy will be. But it might be therapy that will be provided to your daughter, your spouse, whoever the patient is, but it might be you are the one that it's being educated. So now this person's 50 years old, and so I doubt that this is happening in this case, but in some cases, I'll see parents, grandparents who are providing care for, they start out with a young child or even a baby, and they are used to picking up their child or baby, as you would a child or baby. And as time goes by, they don't divert from that. And next thing you know, I see adult people trying to pick up teenagers like babies because they've never been taught to transfer. So take advantage of that. You get 2 weeks a year. So you can do it every year, 2 weeks, you can do this. And so look at that to make sure that they are getting the transfer that they need, but also you're getting the education to help yourself as the caregiver in what you need. Payers are being far more lenient with getting transfer equipment as a person ages. So if you have somebody who's 50 years old and you're the parent of that person, you're going to be up in your senior years. And so you might be getting some shoulder trouble, you might be getting some back trouble. So the payers are getting much more lenient in buying transfer equipment for the individual with paralysis. It can't be for you, so it won't go on your insurance, but it'll go on their insurance. But the person who's using that equipment is you to help transfer. So look into that also with your healthcare, with the patient's healthcare professional, to see how you can take advantage of some of these things that are happening to becoming alive right now, which is very nice. Here's someone whose sister is having some anxiety about learning to transfer on a transfer board. Can you help? Well, I would hope that I could give you some tips, and I hope that I can help, because when you're learning a new transfer, it can be quite frightening with paralysis. If you don't know where your body is in space, you have problems holding up your body, and all of a sudden you're on this, I'm going to slide across from my bed to my wheelchair on this transfer board, and it can be quite frightening. Reassure her that somebody will always be with her when she first learns to do it. So it's not going to be like, here's your transfer board, now start moving on it, and I'll see you later. There will be education that will come along with it, and there will be a lot of practice until they're totally comfortable with transferring on that transfer board. They'll give you a lot of tips and a lot of different things that you can do to strengthen your arms so that you can move yourself along. So I should mention, a transfer board is either a plastic molded board, or it's usually a piece of wood that's been heavily varnished, so that when you have your clothes on, it helps you slide your lower body along as you use your arms to move your body, will help you slide, so you can make that crossing between the bed and the wheelchair. There's nothing, if you can't pick yourself up, your body up, it will help. It helps you transfer. So it's been used for years, and people become very adept to them. Now, if you're transferring from the shower chair or the toilet, you don't have your clothes on, your skin sometimes sticks to those. So you can use some baking powder on there. You don't want to use talc, because especially for the ladies, that's not a good thing to put in that area of your body. The talc, that can can lead to other problems later down in the future. So use some baking powder to just put across that board, and that will help you slide across that board. So they'll give you all kinds of tips, and they'll stay right with you until you learn how to do that. Risk for surgery for someone at the age of 77. Um, they're thinking about advice for colostomy bag success as the bowel program has not been successful and hinders everyday aspects of life now. Well, be sure you get our bowel program management book, because oftentimes there's so many little nuances to the bowel program that people are just not educated about, like sitting up and helping gravity do it. Be sure that when you're doing your bowel program and you're putting the suppository in, that it's up against the skin. If there's bowel already in the rectum and you can't get it up against the skin or up against the bowel wall, if you can't get it in that spot, it's not going to melt. It takes body heat to melt suppositories. I know there's a question later on the difference between Magic Bullet and Ducalox suppository. The Magic Bullet does not have a coating on it. The Ducalox has a vegetable coating that has to melt before the suppository can begin to work. Again, it works by body heat. So getting those kind of things done. Still, there are people that still have problems with their bowel program. Also, looking at your fluid intake and looking at roughage that you eat. So there's also those problems with that. So looking at risk of surgery for everyone, the risks are the same. Breathing, bowel, regaining bowel function, um, bleeding. They're all the risks that everyone has with surgery. I am always so surprised how nonchalant people take surgery. Surgery is a very risky procedure. Now, I don't know what the percentage is, but most of the time it comes out fine. There's a little more risk if you have paralysis, because it might be longer to get off the ventilator. You might not get off the ventilator. But a lot of people, some people decide to try a colostomy bag instead. One of the biggest problems with the colostomy bag is that it's very difficult to maintain on an abdomen that is not hard. And when you have paralysis, that abdomen becomes lax. And so it's hard to keep it on there. And so you work with a colostomy nurse who will help teach you how to put that bag on. Sometimes with the amount of stretching that's done, moving from wheelchair to bed and transferring, sometimes they just pop right off. I look at the pictures for placement of colostomy bags, and every single person, every drawing, they have a six-pack. I don't know people with paralysis who have a six-pack. So it can be a challenge. There are belts that you can use. There's extra tape that you can use. There's all different kinds of things. So you have to keep trying until you find the right bag. Sometimes you get to choose, when you have an elective colostomy, where the colostomy bag is located on the abdomen. You can choose that. So if you have it closer to the outlet, to the rectum, if you have it lower, on that side of your body, the stool will be more formed. So it comes out, a little more form, a little more thicker. If you get it on the other side where the stool is still watery in the large intestine and a lot of that water hasn't been removed, sometimes it shoots out so fast that the bag blows off. So talk to your surgeon, work this out, what's right for you, and just make decisions on that. I did write a blog at one time about all the different things about the colostomy bags. So if you look on the foundation, you're going to find it. And in fact, look, it's right there. Our faithful information specialist, Donna, has colostomy link right there for all that kind of stuff. Oh, Peter, thank you. He's talking about transfers. Yes. Permit me to add that things sag after aging, which includes men's scrotal tissue. And when you're trying to be transferring, that can be a problem. And it can be. So sometimes men will wear briefs, white male underpants to help hold that in place, so they won't be sitting on it. I know something that I learned as a nurse working in rehab a long, long time ago is after you get a man into the chair, it's good to take the crotch of the pants and just give it a little tug to give a little more room so things aren't pinched in there. So, just another thing. Repeat your advice on the benefits of powder. It's baking powder, not baking soda, because that's granular. But baking powder is real soft, so use that on the transfer board, and that will help you get a smooth skin to board transfer. Have most quadriplegics been successful with Botox for the bladder? And yes, Botox is used for the bladder for spasticity. Now, this person says they tend to pass a lot of white stringy sediment. Botox won't help with that. Botox is for spasticity. So sometimes people hear things, they're talking to their friends, oh, Botox works with the bladder, but it only works for certain things like spasticity. The white stringy sediment, some people just have a lot more of that than other people. Sometimes people will notice when they have that, they'll say, "Oh, it ties into when I have a UTI," and that's their symptom. But having white stringy sediment does not mean you have a UTI. It just is some people have noticed that within themselves. So usually that white stringy sediment really doesn't matter most often. Oh, I'm glad I got to this one because I really wanted to answer this question. My husband has a pain pump with Dilaudid, but it's not working very well anymore. His nerve pain is severe. Are there any new developments or suggested for nerve pain? He's C56 Asia A complete. Well, sometimes Dilaudid is put into pain pumps for nerve pain because the medication bathes the spinal cord, and so in pain pumps it doesn't go up to the brain necessarily. But in spinal cord injury, it's put in at the lower part because the medication will stay in the lower part of the spinal column. You don't want this medication at such high doses. You can give higher doses than you can take by mouth, and it works directly on the spinal cord to calm it down and to bathe it. Now, there are different pain medications that are formulated particularly for nerve pain. Dilaudid is not one, it's an opioid, which works to dull your brain senses, but doesn't really treat the nerve pain. It just dulls your brain to make you think that the pain is less. But Dilaudid is one of the drugs that is put into the pain pump. It may or may not be the right one for your husband. So talk to him about a different medication. If you're not getting relief with the Dilaudid, and that usually is put in for pain as a last effort for controlling pain. So I don't know that your husband has tried other drugs or not, but you might want to ask your doctor about maybe trying a different drug, and they can swap out the drug. Now there is a process of going off one drug to go on another drug, and so it can be a bit of a rough patch, but then you try this other drug, and other drugs might work. So talk to your doctor about what is best for him, because there's so many different kinds, and so you really want to do what's really going to relax that nerve pain. And so it might just be that Dilaudid is not the drug for him. And I don't know your husband, I don't know what all you've tried, but and that maybe that is the drug for him. Maybe you've tried everything and this is the last thing to try. If you haven't tried oral medications, the gabapentin and the pregabalin, the Lyrica and Neurontin drugs, I don't know that you want to go back to oral medications now that he's got the pain pump, or maybe in addition to. You can also, drugs for seizures taken in small amounts, drugs for depression taken in small amounts, that won't treat depression or seizures can also be done. So there's a variety of things you can do. Sometimes you have to take the pain pump and oral medications. That neuropathic pain is so unique to every single person. There's not a magic bullet. You can't say, this is the pain that's going to help you. And I wish you could. I wish you could say that. But it is so different for everybody. The dosages are so different for everybody. It's really a process. So you need to keep thinking about the process and how that will work. Osteoporosis treatments. So this person is asking about all the drugs, list possible side effects that are concerning. Some of these medications, and you list possible side effects, doesn't mean you're going to have them, but the possible side effects. And you read the drug warnings, and I urge you to read in that huge piece of paper that comes with every prescription. They have all kinds of information, the side effects, the complications, what drugs shouldn't be taken with it. If you read those three things, that would be a good start. If you read the chemical makeup, I don't know that anybody really absolutely needs to do that unless you're a pharmacist or a doctor or nurse or somebody. But if you read those warnings, it's important to know so that you're prepared, so you're not wondering, oh, what's going on here. But sometimes you get these drugs, and the possible side effects will make you say, I don't want to take these drugs. I talk to people all the time. That's just way too many side effects for me. And so, looking at those can be quite concerning, but you do need to know what's going on. So, I lost my place here on my list of questions. So let me get back to that. But I'll look at that when we finish the drugs for osteoporosis. So if you have osteoporosis or osteopenia, osteopenia is the start of osteoporosis. There's been some change in the bone, but it doesn't have the big holes in it. And it looks like a sponge. Looks kind of like, it's not like a hole, like here's the hole where the osteoporosis is. It's a whole bunch of tiny little holes that damage the bone, that makes the bones brittle so that it can't support your weight. But also they get so brittle, and I've had patients that have such brittle bones from taking steroids or other kinds of things, and even just to pick up their leg as gently as possible and to try to move to turn them, and their bone just snaps because it's so brittle. So you don't want this to happen to your bones. So what are the options? The options are to take these medications. So before you do any medication, before you do any treatment, before you do any surgery, you always want to look at what are my risks and what are my benefits. Well, if the risk that your osteoporosis gets so bad that you're going to have broken bone after broken bone after broken bone, that's pretty serious kind of thing. Versus maybe, I might get nauseated after I take this medication, or, I might have this problem or that problem. If you do decide to take the osteoporosis medication, then it's a good idea. If you start to have any of the side effects and you're starting to wonder, call your doctor right away. See if you should continue. Maybe if you have a little nausea when you first take it, and you take it for a week or a month, maybe that nausea, resolves over time. There are pills, there are shots, there's an IV treatment. So look at the different kinds of treatments. Maybe you don't want the gastric upset or the bowel upset with the oral medications, but you can take an IV medication or a shot, and maybe they don't have those same side effects. So, talk to your doctor about everything about you, what you're worried about, and what you think might happen. And it could be you might take that pill or you might take that shot and you never have any side effects at all. So the benefits outweigh the risk for some people. And if you catch it earlier, you don't have to take that medication for the rest of your life. You get it treated. After it's treated, you can get involved in some therapies to help you maintain your bone density instead of taking the medication. So just because you have this problem and you have to take the medication, it is not a lifelong medication for everyone. Some people take it a long time, but it is not necessarily a lifetime of medication for everyone. So know those things. And if you catch the osteopenia in time, you might only have to take it for a few months or maybe a year. It may be longer, but if you already have gone into osteoporosis, you're going to have to take it for a longer period of time. So these are the kinds of things you always want to weigh your risk versus benefits. If the doctor says, I'm giving you this medication and you don't like the side effects, talk to your doctor about, is there a medication that wouldn't have this particular side effect that I'm worried about, or that has less side effects? Unfortunately, osteoporosis medications do have some side effects. And when you read that whole long list, it can be frightening to death. Oh my gosh, I'm going to get all this. Just means possibly you could get, more likely, some of them, but not all of them. So, and some people get none of them. Be sure and follow the directions. So if you take the pills, you have to sit straight up for a certain amount of time. You can't eat after a certain amount of time. You want that pill, you want to follow all the directions because you want that to work as best as you can get it to work so you can get off of it sooner. So, that's that's just one of those things that you need to think about. Somebody has written in about the improvements to intermittent catheterization coding and coverage policy that's effective January 1st. And they're curious if that will have impact on plan of care with regard to catheter selection at the time of discharge. That is a very interesting question because usually what we try to do is we try to get an understanding, and the case manager, the hospital case manager, there's several case managers all around the healthcare system. The hospital case manager can check the insurance policy to see what the patient will be using at home. Then they can order those catheters in the hospital if the hospital will allow it. Hospitals sometimes have contracts with people, and this is the catheter that we're using, and so that's the way it is. And then somebody goes home, and they have a different catheter, and they're like, "Oh, wait a minute, what is this? What do I do now?" In the hospital, you get a kit where everything's all in the kit, the little tray to empty the urine, the catheter, an individual pack of lubricant. Everything you need, is the cleaning fluid is all right there. When you go home, there's going to be catheters that are given to you. There may or may not be a bag if you're catheterizing on the toilet, or a bin to catch the urine in. The tube of the lubricant's going to come in a tube as opposed to in an individual package, which you never let the catheter touch anything in the tube. You drop the lubricant on there. Sometimes people learn in the hospital to put the catheter inside that individual packet of lubricant, which is not a good thing to do because there's too much risk of the catheter touching the edge of the opening of the lubricant, or there's too much risk of infecting the tube of lubricant. Sometimes people only have one tube of lubricant and they're also using it for their bowel program. And so that tube of lubricant can get pretty gnarly. So you just want to it's best if you can have one tube for your bladder and one tube for your bowel, and then drop the lubricant on the catheter. And the cleaning solution will be in a separate package altogether. And most of the time you're using soap and water when you're at home. So get a really mild soap that doesn't irritate the urethra, and be sure and wash the soap off when you're finished using that soap because it can get up in the urethra and irritate. So there are all these different things. It's a different ball game when you get home. And so when you get a whole different catheter, it's like, oh my gosh, now what? Because maybe you use some of the real exciting pre-lubricated catheters, or maybe one that has a bag attached. They're really easy to use, but have the hospital case manager either check the policy or talk to the insurance case manager so that they'll know, so that the hospital can get you the type of catheter that you'll be using at home, so you'll be able to do it. Most people don't have much of a selection. They are given what insurance pays for. Now, you can always buy catheters on your own, but that is going to be a bucket load of money. So you want to get what you've already paid for in your insurance policy, which is one that insurance has given to you. Oh my goodness, it's so complicated. Now, there are different programs through different catheter companies where when you are at home, you can contact them and you can ask them to send a trial kit of different catheters. And they'll send you all different kinds of catheters that you can try at home. That doesn't mean that insurance is going to cover that catheter when when you oh, hey, I found one of these real high-tech fancy ones and I want to use this real simple one. Well, yeah, everybody does. But that doesn't mean insurance is going to pay for that. But if you find one that works, the catheter company will work with the doctor to try to get your insurance to cover that particular catheter that you like. There's a company in Florida called American Freedom Catheters. I think it's a family-run company, and they started doing this years ago, and they are really good about trying to get the right catheter for the right people. But the big companies now are doing the same thing too. So we can be hopeful on that. And as things evolve and these catheters become more common use, the advanced ones I'm talking about, then those catheters are going to become more available to different people. Now, also be thinking about, there's so many questions about bowel programs and bladder programs, skin management. Those are the big three. They're the big three things that you have to look at. Now, if you are high level and you're on a ventilator or you use some kind of breathing, that's number one. But breathing is always number one. But bowel, bladder, and skin are always the big issues. And it can be kind of daunting to think, oh gosh, I'm going to be managing my bowel like this for the rest of my life. I'm going to be managing my catheter like this for the rest of my life. Now, after you become used to doing it, more comfortable doing it, and you can find you can get these things done in a short amount of time. However, it is time now that we need to start thinking with all the new technologies that are out now and more coming. And we've always been through paralysis, we've always said this is coming, that's coming, and years go by and nothing ever happens. Well, it's all happening now. And so it's very important to remember that you're probably not going to be doing these things for the rest of your life. The more plentiful that some of these stimulation devices come that help bowel and bladder function, that help with hand function, things are going to be getting easier. Now, one company has come out and they have a product on market to help with function, and it involves a strip of tape with electrodes on it, goes down the spine. Put it up higher, it can help with hand function. Put it down lower, it can help with bowel, bladder, and sexual function in men and mobility functions. So, and they're releasing this across the United States. Now, it takes time for it to get out. It's approved, it's out, it's on the market. It takes time for it to get out across the United States because people have to be educated. Doctors have to be educated in how to use this. Therapists have to be educated. Nurses have to be educated in how to use these things. And then once you have them, how to train your body, because the responses for the users will tell me, well, it's a different feeling that I'll have, but I know when my bladder's full now. There's a lot of things that are coming out just with bladder care to signal to you when to empty your bladder so that you don't have to always go on this real strict time schedule. So there's just so many things that are really, truly coming out and are out and that are coming. So even though you're doing it now, don't get thinking, well, I'll be doing this the rest of my life, because you probably won't now. Now, do I have a time for how long? No, you still have to do it today. Yes, you still have to do it. It's not like you can just sit and wait for these things to come, but they are coming. So I think that we have so much hope on the horizon right now. Will it be like before you had your paralysis? Probably not. But it's such an improvement in the way that things are going to be, people are going to be functioning so completely different in the near future. And as I say, it takes a long time. It might take 10 years before these become everyday common items. There's going to be insurance that's going to be involved to get these things, but these are all kinds of things that are on the horizon, and life is going to look a lot differently. Oh, the name of the tape that I just discussed, it's out by the Onward Company. And so there are some other ARCEX is a company that is putting out one as well. And yeah, Nicole, thank you. Because, we talk about all these things all the time because there was nothing before. This is the way that it was going to be, but it's not the way of the future. It is the way of today, but it's not the way of the future. So I'm wishing you all well, and I hope to see you next month.